On this episode of the Ask Mike Reinold Show, we talk about how we know when to push or back off when we work with somebody.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Before we get to the podcast, I wanted to make sure you knew about my free online course on the Introduction to Performance Therapy and Training. If you want to learn how to get started optimizing and enhancing performance, this is the course for you. Head to mikereinold.com/performance to sign up today. Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. We're here answering your questions. Anything you want to talk about, head to mikereinold.com, click on that podcast link, and fill out the form to ask us a question. We're here for you. Let's see. Today we have Jonah Monlock, Lenny McCreena, Dave Tilley, Kevin Coughlin, Dewesh Podell, and Dan Pope answering your questions. Len, who do we have for students today?
Lovely students today. Lovely. Another week of these amazing students. We'll go from the middle. We'll go Sean Riley from Creighton University. Where's that? Is that Nebraska? We have Mike Bearden from Georgia Southern, the home of George Davies, a very good friend of ours, and I would say the godfather of sports medicine. We have Brennan Hammer from Duke University, the home of Chad Cook. We have we already did Brady Cannon, but Brady Cannon, Franciscan Monks of Universities in Louisiana, the home of Phil Page, another friend of ours. And Michaela Meyer from St. Francis University, the home of St. Francis.
That's pretty good, Len. I think you're pretty good. You got notes, don't you?
I have notes on where they're from. That's why I messed up Michaela's name, the first one, because I hadn't written all my notes yet. But I don't have anything else.
Way to prepare. I love it. That's awesome. That's good stuff.
Wing
I love it. All right. What do we get? What do we get today, students? Let me see. I think Michaela's got the laptop. I don't know if that means she's up. But who do we got? What do we got?
All right. So we have Sarah from California. I've been a PT for about 5 years now and still often feel unsure when to push or back off something during rehab. How do you know when you're pushing too much or too little?
That is a great question. Probably one of the things we talk about the most, like in and around, right? You know what I mean? Like that's such a topic of even just like progressions of exercises or range of motion post-operative, that type of thing is how do you know when to push? How do you know when to slow down, right? And it's kind of funny. I've seen this commented on social media, and people like try to give you an answer on social media saying like, never push or something like that, never push, something like that. And it's one of those things. There's so many variables that sometimes you need to push, sometimes you need to back off, right? Like it really depends on the situation. So, all right, who wants to start this one? Dave?
Yeah, I just had this conversation. It might be on the Kayla or somebody else, but I think one thing that's tough about orthopedic PT and maybe why we're a little bit different is like, I think a lot of PTs are good intention, but they don't understand what a normal hard training session is. And I think like the strength coaches we have understand that very well. And I think the PTs are great, but like there are times when you're pushing someone and they're a little sore or, they're a little tired or whatever, or the next day they get sore, but it goes away within like a day and it never really bumps up into like an acute pain situation. They're just like sore and tired. It's global. And like, that's exactly what we want. Like people need to be pushed and challenged to get stronger and to get back to the stuff they want to do. And I feel like that's usually a really important baseline is like, you have to understand what a normal, healthy response to training is before you start to say like, was this too much or was this not enough? And I think there are proxies you can use that are a little bit more like, okay, this is dabbling into maybe not productive, which is like the swelling increases maybe at a knee joint, or like the range of motion goes down acutely because there's some like mild, effusion and they lose 5 degrees of extension or 5 degrees of bending, or their pain is very specific to one spot and they have trouble with their ADLs, right? Or it doesn't go away in 2 days. It stays elevated over the weekend. Like those are rules of thumb you use to be like, okay, maybe this is more of we're irritating the tissue. We're not getting a global training response. So that's pretty much always how I guide it is what's normal, is this abnormal, and why, from swelling, range of motion, ADL, stuff like that.
I like that. And I like how Dave in his head, right? Because it changes for what you're dealing with here. Is sometimes one of the metrics that you look at on how well they're tolerating the progression is the body's response, right? And I like how you said it. Did the knee puff up, right? That okay, so maybe you did too much. And by the way, like it's really, you work with them for what, 2 to 3 hours a week, right? And they have a lot of hours on their own, right? The rest of the week, right? So it's not always did you do too much, but as a whole, are they doing too much? So I like that. That's a good one. What else? Who else? Dan, what do you think?
Yeah, I know we chat about this sometimes, but I also think it's going to depend if someone's, let's say, non-op or post-op. And I think a good example, and maybe this is an outlier, is like a rotator cuff repair, where I'm sure like you guys have seen this. Every once in a while, you get a massive rotator cuff repair. They come for initial evaluation. They're 2 weeks out from the surgery. You're like, oh, I'm feeling great. And you're like, whoa, 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 stop, stop, stop. And that's one of those situations where it's like, okay, we can't be doing that. It's putting a lot of strain on that repair site. Need to back off. And this is where protocols are actually kind of nice. We say, okay, at this week we can start to slowly introduce this and start to ramp up. And hopefully the protocol is made with some sound logic, some research, maybe some EMG studies, some thought with it, right? And then I also tell patients, in terms of pain, if it feels tolerable, you're allowed to do it at that point. And the next day you feel pretty good. Your range of motion is still improving. Your pain's going down. Your function is getting better. Your strength is improving. We're moving in the right direction, right? So we're kind of monitoring for symptoms. I think where it gets a little bit more confusing are those non-op patients that come in with, let's say, a tendinopathy, right? Joint-related pain. Maybe a bone injury is a bit different because we probably shouldn't be pushing through pain. But for folks with tendon problems, joint problems, we probably can push into some pain. And at least from an exercise prescription standpoint for athletes, and it's probably going to change for the average person, you probably want to push them as hard as they're supposed to be pushed at that point. So if they're, like, say, an off-season soccer player and they need to work on strength 3 days a week and conditioning, whatever it is, we want to maintain that as much as possible. So in terms of exercise prescription, A, we want to continue everything as much as you possibly can within tolerance. And you can use the pain monitoring model. So less than a 5 out of 10, back to baseline, kind of like Dave said. And over the course of time, if you're progressing, getting stronger, pain going down, you're doing great. When you're choosing exercises, you want to try to support them as close as what the sport's needs are, as much as they can possibly tolerate, because the higher level exercise you give them, the more of a response you're going to get. So that's kind of my go-to. I mean, if you're concerned you're going to cause a flare-up, start with something easier and over the course of time ramp up. But I think you're trying to meet the athlete where they are.
I like that. And it's a good way of like shifting to your thought process and understanding that somebody that's a post-operative surgery that has healing constraints, right? There are actual constraints on tissue that needs to heal. That's a lot different than somebody needs to be pushed, right? So I like it. Dan kind of commented a little bit on like how we use pain sometimes. And sometimes you want 0 out of 10. Sometimes you actually want 3, 4 out of 10. Like that's actually part of the prescription. Strength coaches, maybe Jonah, if you don't mind jumping in. How do you instruct somebody to push their intensity appropriately then, right? That's pain. But how about somebody that's not in pain? I think in physical therapy, like Dave kind of alluded to this, I think, but we chronically underload, I think. I just think like, we underload people a little bit and don't push them enough. How do you know that they're doing enough loading, and how do you get somebody to pick like the right intensity when they're doing exercises?
Yeah, I think there's kind of two main things that pop into my mind. So the first is just being aware of who the person is in front of you. Are they an older adult, a younger kid, someone who's new to the gym, where maybe our main goal is just to get them to enjoy working out and starting with that. And then over time, worrying a little bit more about the intensity, versus are they a college athlete who's with us for 3 months in the summer and is trying to get more playing time that fall, in which case we do need to push things a little bit more. Or are they a professional baseball player? Similar thing. They need to increase velo or exit velocity or whatever it is. So one is just starting with who is that person in front of us. And then a second is almost trying to give them opportunities to learn those things for themselves. So one of the strategies we'll use is having sets where they're doing as many reps as they can of a similar exercise they've been doing. And we're standing there, we're cheering them on, we're telling them get 2 more, get 2 more. And all of a sudden they do 5, 6, 7 more reps than they had been doing in training previously. And then we can have a conversation based off that of, okay, that's what a hard set feels like. Not every single set has to be that max effort, but that now you know what hard is. Let's train a little bit closer to that. Or another tool is something like a gym aware, where you're giving them a targeted speed, and it might be something that's really slow and they're still lifting heavy, or it might be something that's really fast with a lighter weight. But in either way, we're cueing them or teaching them go as heavy as you can where you're not dropping under this targeted speed. So if the target speed is 0.5 meters per second and everything they're doing is in the 0.6s, go heavier. And we just tell them keep going heavier until they fail. So giving them opportunities to learn by themselves by approaching failure and trying to just learn what it feels like to actually train hard.
I think that's so important too, Jonah. You said that so well. It's about education. They need to understand that, right? And then for the advanced stuff, you can use metrics, right? But it's about education, right? So that's huge. So I just summarize a couple things. One little tip that I do sometimes is I just simply ask the person. This is usually early on in that process. Was that easy, moderate, or hard? Right. And they never say hard, right? It's always easier or moderate. So whatever they say, you just say like, all right, let's add weight to that, right? And you go up, and then eventually they're like, okay, that's hard. And it might have took 3, 4 times for you to add some weight to do that, and they'll get there. But Len, did you have anything to add? Did you want to jump
Yeah,
in too? Sorry.
I do because I deal with this a lot. I guess we all deal with it, but I deal with it in my head a lot with ACLs that are 7, 8, 9 months out, or even that early ACL or early Tommy John. I push people, I want to say kind of intentionally, but I do just knowing that if I do aggravate things, it's not going to be the end of rehabs. Like I push a rotator cuff and you can tear their cuff. I could push the knee a little, or Tommy John a little, depending on what I'm doing, and then just see how they do. But I think another key component is seeing how the person responded to the pain, meaning how did that make you feel about increasing the pain and soreness? Because some people freak out if they're pain and they can call it a 3 out of 10, but to them a 3 out of 10 is like a 9 out of 10. So I want how that make you feel about the pain increasing. Some people are like, that felt really good. I feel like we actually pushed it and I feel good about it. And I know I pushed it in a safe way, meaning I had them do a deeper squat. I had them incorporate a deadlift. I had them, go up in their dumbbells after a Tommy John repair or reconstruction. And so it's how do they mentally feel about that new soreness, that new pain that I want to know about too, because that's going to tell me, can I push them even more and they're going to be okay with it, or they're going to freak out and they're not going to be happy with that new sensation that they're feeling. So I like to know the mental component of how they're responding to the new challenges too.
Yeah, I think that's great too. I mean, it's a good way to again, it's part of the education process too. It's like
Right.
they have to educate that this isn't an appropriate, this is an appropriate progression right now. So, Dan, did you have something else?
Yeah, just real fast to add to Lenny's, I think it's PTs don't want to hear this. They want to hear like what is the absolute best thing to do for your patients. But if you look at some of these studies where you push through pain or you don't, the longer term outcome is very similar. So I think the key is do what works for the patient. If they want to push through some pain,
Right.
great. If they don't, great. That's fine too. Probably a large variety of what's okay.
Yeah, and I think more importantly is I want you to think this way, right? Avoid the roller coaster. There's nothing worse than the roller coaster, right? You speed up so much that you panic and you have to slam the brakes on, slow down, and then, oh gosh, we're getting behind again. Let's speed it back up. You got to avoid that. You're never going to have a complete linear progression, right? But you can have little speed bumps, not roadblocks, right? That's the big thing is you don't want to have these gigantic ups and downs. So you make micro adjustments day to day based on what you're doing. So just like you shouldn't pull back real fast, you shouldn't push forward real fast. You shouldn't, go from 90 degrees to 120 degrees one day, just making it up, or double the load that they're doing one day. You have to have that nice natural progression. So I want you to think of that too as you go through. It's like no roller coasters. Just I want to have as smooth of a linear progression as I can. And I think just if you approach it with that mentality, sometimes that actually tells you a little bit. Okay, last time I pushed this much. I'm going to do a touch more today, but not more. And I think it gives you a little bit more of a goal in your head to shoot for that hopefully ends up helping the patient. So great question. If you have anything like that, head to mikereinold.com, click that podcast link and ask away. And be sure to subscribe on Apple Podcasts or Spotify and rate and review us. We do read those things and appreciate everything that you guys send. Thank you so much. See you on the next episode.